Well, good evening, everyone, and welcome to the Navigating Insurance Plans for Arthritis webinar. My name is Heidi Sedlmeier, and I'm the Director of Online and Community Connections here at the Arthritis Foundation, and I'll be your moderator this evening. As a person living with arthritis, I have juvenile arthritis persisting into adulthood. I've had a few different careers and insurances along the way from my employers, but I've also spent 10 years where I was receiving SSDI benefits. I'm particularly interested in tonight's topic because as a Connect Group facilitator, I frequently get asked questions by my support group participants about what they should consider when making decisions about selecting the right plan for them. Having a chronic condition like arthritis can be costly, but careful planning can help reduce some of this financial stress that we feel. That's why tonight's experts and I will share key information on how to choose the right insurance plan for you and ways to advocate for yourself so that you get the care you need. So a few housekeeping notes before we start, or as we start tonight's event. We have muted all the attendees for this event, but you can direct any questions you may have throughout the presentation in the Q&A box on the bottom of your screen. We'll start with a brief presentation, followed by a roundtable discussion. We've actually reserved some time to answer questions at the end of our discussion. Any questions we don't have time to get to, we strongly encourage you to refer to our helpline at arthritis.org/helpline. If you haven't already, please consider filling out the Arthritis Insights Assessment. It only takes 10 minutes to complete, and doing so helps the foundation develop programs that speak to what's important to you. After tonight's session, you will receive an email asking you about your experience. These surveys help us to track the success of these sessions and better plan for future events. So please take the time to fill them out. So let me get started by introducing tonight's esteemed expert panel. Alicia Sullivan has been the practice manager with Rheumatoid Associates PC, Rheumatology Associates PC since 2005. Her commitment to maintaining treatment access for her patients has led her into a more proactive role with advocacy. She currently volunteers at the National Organization for Rheumatology Management and serves as their vice president. Anna Hyde serves as Arthritis Foundation's Vice President of Advocacy and Access, where she leads its mission to improve healthcare access for people living with arthritis. Together with her expert team, she is dedicated to reducing barriers to care and making healthcare more affordable through the passage of laws and policies. And we have Christina or Chris Reeg, and she is the program director of the nationally recognized Ohio Senior Health Insurance Information Program, housed within the Ohio Department of Insurance. OSHIP provides objective, unbiased Medicare information to those on Medicare, their caregivers, and their families. Her many responsibilities include overseeing grant funding, budget, and staff management, partnership building, outreach, and education strategies, and consumer service counseling. Heidi Barrett is joining us also, and she is the Washington State Advocacy Chair for the Arthritis Foundation's Local Leadership Board and has been a Platinum Ambassador for several years. She is a mom of 5 kids, 4 of whom live with psoriatic arthritis, which she also has. In 2020, Heidi was the recipient of the esteemed Edward M. Kennedy Advocacy Leadership, recognizing her service in the arthritis community. Thank you all so much for joining us tonight. Before we dive into our discussion, I'm going to hand it over to Anna Hyde for a brief presentation about important insurance terms and concepts you may need to know. Anna?
Hi, everyone, and thanks for having me. I'm so pleased to be here. Let's go to the next slide. All right, so let's start with just some very basics. I don't want to spend a lot of time here because You may already have some familiarity here, and I'd love to spend the majority of the time on more of the sort of tricky questions that folks might have. So just at its basic level, there are multiple types of insurance plans. Many of us get our insurance through our employers or some other private insurance source. It could be that you get your health plan through a federal exchange or a state exchange, which are Affordable Care Act plans. And, I think the important thing here when looking at what type of insurance you have is to know where it's regulated. If you have employer-sponsored insurance and your employer is self-funded, it's going to be regulated federally through a law called ERISA. If it's fully funded, though, or if you're on a state exchange plan, then it's going to be state regulated. I feel like I'm already getting past the basics here. I have a hard time not diving right into the deep end of the pool. But I just want to put that out there because as we go, if we're talking about specific kinds of challenges that you may be having and whether there are laws that, are out there to protect you from certain challenges, that's where that really matters. If it's a federal or state regulated plan is going to determine whether it's a state law or a federal law that's going to give you those protections. So I just wanted to put that out there. And if you'd like, we can talk through how to find out if your health plan is regulated at the state or federal level. But moving along, Medicaid and Medicare are the other two most common types of insurance. Medicaid states have a lot of latitude about the type of coverage that they can offer through their Medicaid programs. So it's kind of a partnership between the federal government, who does set some benchmarks, and then the states who administer the Medicaid plans. And then Medicare is federally funded. That is available for people who are over the age of 65 and or on disability. So there's a whole set of kind of laws and regulations just for Medicare. So I'll make sure that as we go, we differentiate what applies to what. Okay, next slide. All right, so these are some of the basic insurance terms, sort of the 101, just some things to really be aware of when you're thinking about what health plan that might be sort of best for you. I should also say, because it is open enrollment time, for many of us, these are things to really be familiar with now, and it's why we're doing this webinar right now. For federal exchange plans, the open enrollment period is going to be November 1st through January 15th. So it's coming right up. If you get your health plan on the exchanges, that's going to be really important. If you're Medicare, it's going to be October 15th. So currently already open through, I believe it's December 15th. The dates are tricky to keep in mind. So the exchange plans go through January 15th, Medicare through December 7th, I believe. And so it's a relatively short period of time to do a lot of the research and make sure that you kind of know what's going on. And I know Chris Reeg will go into a lot greater detail than I could ever hope to go into about Medicare and kind of what to know, because we certainly know that transitioning on to Medicare or choosing the right Medicare plan can be really difficult. Lots of options to choose from, and it can be a little overwhelming. So, a lot of employer plans also do their open enrollment periods around the fall. Not everyone does those. That's really important to know kind of when your employer's open enrollment plan or open enrollment period is, if you do get your coverage through your employer. So the premium is going to be the amount you pay on a regularly scheduled basis. If you're through your employer-sponsored insurance, then it's probably going to be per paycheck is where you're kind of paying premiums through your health insurance, just your base premiums. But then certainly when you go into a doctor's visit or get a prescription filled or have any sort of service, you may have some of these other things here apply: a deductible, a copay, a coinsurance, etc. Your deductible is going to be a preset amount, and it can be anywhere from a few $100s to a few $1,000s that you have to pay out of pocket before any of your actual insurance claims kick in. A copay is a fixed amount you pay for a covered service. So you may see on your health plan materials that, a visit to the doctor's office might be $25. So that would be a fixed amount. Coinsurance, on the other hand, is usually a percentage. So instead of being $25, it might be 20%. That is a crucial distinction to make, because 20% of $500 is going to be very different than $25. So It's really critical to know whether the services, the provider services that you typically rely on, and prescription drugs in particular, look for where those are in your health plan and what the requirements are about whether there's a fixed copay for your prescription drugs or a coinsurance, because again, that percentage could add up to a lot more than just a fixed copay. So that's really important to know. Out-of-pocket limits, there are out-of-pocket limits for most people. The Affordable Care Act did include a maximum out-of-pocket every year that individuals can pay. And after that, everything should be covered. Of course, it is also important to know that that applies to services that are in network and prescriptions that are on the health plan's formulary. So if you go outside of those parameters, then you might be on the hook for costs that are not going to count towards your out-of-pocket. So that's also really important to know. Whether the services, whether your providers are in network, the services are covered in network. Those are always good questions to ask. You can usually find that information through your health plan's website. But if you're having a particular service, especially if it's a surgery or a hospitalization where you may have multiple touch points with multiple providers, it's really good to ask ahead of time, is all of this in network, and make sure that that's the case. Same with prescription drugs, making sure that the drugs are on formulary. And if you're not sure, you can always ask your health plan, give them a call. And then the formulary, of course, is the list of drugs that the plan will cover. There usually are different ways that they cover them. It's not just, here are 10 different drugs and they're all on formulary. Usually there are tiers. So there will be a tier for generic drugs. There will be another one for preferred brand drugs and another one for non-preferred brand drugs. So if you choose a drug that's on the non-preferred list, you may have higher cost sharing. It may be a co-insurance, for example. We know that co-insurance tends to be more common for specialty drugs like biologic medications. So that's something to watch out for as well. And then increasingly, health plans are using specialty tiers for specialty drugs. So that's another thing to keep in mind. Make sure you know when you're looking at your health plan terms, what the formulary tiers are and where the drugs that you rely on fall within those tiers. Okay, next slide. And this is my last slide. So this is just kind of a visual example of how this might look if you have a $2,000 deductible. So I won't go through this word for word, but just to kind of show that essentially at the end, you are going to have to pay that out of pocket. So it's $100 for the office visit, or it's, a certain number of dollars for, a lab test or a prescription drug. You're not paying that $25 copay. You're paying whatever the price of that service or treatment is until you hit that $2,000. So in this scenario, this patient needed to have surgery, and they had $1,400 left and to cover through their deductible. And so they had to pay that $1,400, and then the health plan kicked in the rest. And so from here on out, their deductible has been met. So they're just, for the rest of the plan year, they're just going to pay the co-pays and co-insurance and those things that are associated with their health plan. So I will stop there for the moment. There are a 201 and 301 level of terms that we could certainly go into, and I hope that during the Q&A and just the general discussion that we'll get into some of those things, because there are certainly trends and certain terms that we're seeing, certain policies that we're seeing health plans increasingly use that we want our volunteers to be aware of, so that you just have a little bit more language to use when you're looking at your health plans to kind of know what's what. So we'll get into that in a little bit, but I will stop there and turn it back over to Heidi to take us into the next section.
All right, great. So we're going to dive right into our roundtable discussion. And first topic we're going to tackle is choosing the right insurance plan for you. For many people on the call, it is open enrollment season. That's the time of year when you can sign up for health insurance, adjust your current plan, or choose a new plan. So let's start off by discussing how to choose the right insurance for your arthritis care needs. What's the main thing to consider when choosing a health plan? Anna, would you like to get us started?
Yeah, I may have already covered part of this. Yeah. And I'm very curious to hear what my fellow panelists have to say. But I think, especially if you are already on a treatment plan, you already know what medications you take. what providers that you see on a regular basis when you're looking at health plans. And it's important to do this every year. Don't assume that just because you have the same employer or they're using the same health plan company that everything's going to be the same. Every year there are going to be differences. The co-payments may be different, that sort of thing. So if you take prescription drugs, definitely look at where your drugs fall in those tiers and what the requirements are. Because like I said, the co-insurance can be extremely different than a co-payment, especially if you're on a biologic medication that could be thousands of dollars a month list price. 20% of that is going to be high compared to a flat copay. So definitely look at that. If the plan materials don't give specifics, don't be afraid to call the health plan to ask, I'm on this drug. I want to know, what the cost sharing requirements are. I want to know if you have fill limits or if I require a different dose or things like that. I want to know what your exceptions process is. Be aware of that. I'm sure we'll get into some detail about that a little bit later. Also, make sure your providers are in network. Provider directories change and networks change frequently. So it's always good to go through your list of doctors and make sure that they're all still covered. And I think another important thing is to see if there are any other sort of requirements or prohibitions or limitations that health plans might be introducing on how you might be able to use things like manufacturer assistance, copay assistance, and things like that. So, we can get into some of that terminology in a minute, but I'd love to know what my fellow panelists think.
I think that copay assistance is really important to take into factor, because if you have huge deductibles, which I'm pretty sure just about everybody does at this point in time, if you have copay assistance and you time things right, it'll eat things up. As far as your deductible, your out-of-pocket costs go, you just want to be careful that if you have a copay accumulator plan, which is illegal in some states, so you want to know about that kind of stuff, that's when your plan will take the manufacturer and not count it towards your deductible or your co-insurance and say you're still responsible for it. You just want to make sure that you're getting everything that you can to take care of your out-of-pocket costs so that you're ready to go with everything else that's lined up. So I'll try to get our patients to have their treatment before they need an echocardiogram or whatever else they need to have taken care of.
I'll just chime in for the Medicare folks, but I think these ladies have shared some vital information in comparing plans. The Medicare patients would have received at this point in time their annual notice of change, or ANOC. That is a document that's going to address any changes for the upcoming calendar year in their current plan. And that is a great foundation to start comparing plans during the open enrollment. If already you see in your plan that your premium is doubling or tripling, that's a huge indicator that it's time to check. I'll now reiterate, Anna mentioned the formulary and the network. Those are two very important topics for folks, especially with chronic illness.
Would you like to add anything, Heidi? Or?
Yes, I was to say, when you go to check if you're going to switch plans, it's a really good idea to have your EOBs from the previous year or previous 2 years, so you really understand what you're paying for and out of pocket, so you can have a better comparison. Just going, oh, that copay, that co-insurance is really expensive, or the deductible is, but that's not the entire piece of the puzzle, because everyone's different on different medications, et cetera. So it's really helpful to have a couple of years worth of, oh, this is what I'm actually paying before.
Another thing, Heidi, that, in addition to the cost of your treatments, it's also good to know what we call utilization management protocols your health plan might require. Utilization management just means different, sometimes restrictions or limitations or things that you have to do before you can get the medication that your doctor prescribes. So prior authorization is a very common one. And it's also important to know that prior authorization doesn't necessarily last forever. You may be on a drug for 10 years, but you have to have it prior auths every year, or even sometimes more frequently than that. So knowing those requirements is really helpful. Step therapy is another one we hear a lot, where your health plan prefers a different drug than the one your doctor prescribed. And so you have to step through that other drug before you can get the one your doctor prescribed. And there are exceptions processes typically, and you can file appeals, when you get your prescription denied. So knowing those processes is really important too. Mid-year formulary changes are often allowed with health plans. That's another sort of legislative issue. In many cases, there are a lot of states that prohibit mid-year formulary changes, but that's also something to be aware of. Does your plan allow for the formulary to change? And all of a sudden in the middle of the plan year, the drug that you're on may not be covered in that same tier that you're used to. So those are things to be on the lookout for as well.
Great.
The only other thing I would add is that a lot of times insurance brokers who are selling these plans, especially if it's Medicare Advantage, you're leaving the pharmacy at the supermarket and they're trying to sell you something. They don't understand the full plan that they're actually selling you. So even if they do understand enough to look up your medication and is it covered? Yes, it's covered, but it's a 20% coinsurance. Is that affordable? And they might say, yes, it's affordable. And even if they go the extra length and they look up what that cost would be, they might be looking up one billing unit. And that one billing unit may be a 400 billing when we're putting it to the insurance after whatever the medication is. So you have to kind of know more of that than your insurance broker does when you're making those choices and trying to pick that plan. So I constantly try to remind our patients and other people to either call the Arthritis Foundation helpline or talk to somebody on our staff that knows a little bit more, just so they can kind of navigate that a little bit easier.
And I'll reiterate that because we are in the Medicare open enrollment. And I think this is going to come up a few times in this call. You can't turn on a television set. And that's saying something with the political ads. Your email box, your mailbox, your text messages are bombarded with sales. And it typically is for the Medicare Advantage products, which is Medicare Part C, or the alternative to original Medicare. And often these brokers are lead agencies just trying to get you to call them. If you see a famous football player or a comedian, it's a lead agency and it's going to connect you to a broker, typically Florida, Texas, out of state, who know nothing about the local landscape and certainly lack the time to really make that an individualized choice, as Alicia alluded to. There's a lot that goes into selecting your health plan. And I can't stress enough, you're choosing your health insurance for health insurance. These added benefits that are marketed like grocery cards, money toward utilities. It's wonderful and they can be a huge benefit, but what value are they? If you're getting $50 a month in groceries, but as alluded to, your $25 copay for your medication changes to 20% and equates to hundreds of dollars, there isn't a value to that added benefit. And, we'll get into it with the Medicare service, but please make sure to get objective assistance when looking at these benefits.
Yeah, I really hear do your due diligence. All right, let's go to the next question. Are certain plans preferable to others for arthritis? Do these considerations differ depending on the types of arthritis you have? Inflammatory versus osteoarthritis? How do you want to take a stab at this one?
Definitely. Your insurance plan needs to cover your medication at a reasonable price. I know that's a pipe dream, but osteo medicine is not quite as expensive and inflammatory. I mean, I have a son whose medicine's $56,000 for one dose, and we owe 10% of that. So really, you really need to look into the drug coverage with. And the other big thing that I tell everyone, do you like your rheumatologist? Just make sure you have a plan that has your rheumatologist on it, or you might be losing your rheumatologist. So you need to look deeper into, it's not, if you're young and healthy, who cares what your health insurance is? But if you have a chronic disease, you need to be really reading into the fine print and figuring out if what plan is right for you.
Would anybody else like to chime in?
The only thing I would add to that is, I feel like increasingly people are being steered towards high deductible health plans. And in some cases, you only have a high deductible health plan option. But you know, it's difficult because everybody's trying to control costs. If you're a health plan, you're trying to control costs. If you're an employer, you're trying to control costs. And high deductible health plans are intended to keep a check on overutilization. My feeling for a person with a chronic disease like arthritis is that you don't want to be concerned about overutilization. You want to be concerned about utilization. You're not trying to underutilize the healthcare system. You're trying to utilize it, which is different from, you know, Heidi was just talking about. If you're a healthy patient, you're not going to use healthcare very often. It doesn't matter as much. Maybe a high deductible health plan is right for you. But if you rely on continuous access to the healthcare system, a high deductible health plan is probably going to be a bit counterintuitive to you. So it may be similar to what Chris was talking about, where, you know, the premiums might be lower. There are a lot of attractive features to it. But when you really get into it, you're going to be paying a lot more out of pocket on the front end and have less cost sharing protections at the beginning of the plan year. So, you know, there are calculators that you can use. I certainly encourage that. And we have your Coverage Year Care Toolkit on our website that can help people walk through this. But I think in a lot of health plans, you know, offer those services too. Take all of the sort of providers, how many visits you do per year, you know, your prescription drug costs, things like that. And there are tools that you can use to sort of calculate what your monthly out of pocket, and if you have a deductible versus not a deductible, what your cost sharing might be through that deductible period, et cetera, et cetera. So really like actually plug in the numbers and do the math so that you can really then take a look at what makes the most sense for you.
And I would add one more thing. When you figure out what plan, you're like, oh, I've narrowed it down to 2 or 3, give your rheumatologist billing department a call or another specialties billing department that you use and ask them about the plan. They're going to have an opinion on it. And one of those plans might be a horrible plan and you might not be getting your services. So ask them what they're seeing if you know you're down the right path. And they're more than happy to help you with that because they're the ones that are going to get stuck with this horrible insurance plan trying to get it paid for.
Legally, we're not allowed to tell you what you should not pick or what you should
that is
pick,
correct,
right?
but you just
But
say
we
what
have very strong opinions because I've seen so many changes. I started in my practice in 2005, and at that point, I could make a call. Actually, it was usually my physicians. They'd make a call, and they wouldn't be on hold, and they'd get an approval for your medication because there was only so many, and you're good for a year, and that was fine. And then when we started to get we need 72 hours to turn this choice around, I would push back because I'm like, this is ridiculous. 72 hours right now is a really good turnaround time. We do have opinions and we do have advice that we can give, but I've started to actually turn it over to the Arthritis Foundation and their helpline because of how long these conversations take and how many plans are out there and how they market some of these plans. So it sounds great when it's not necessarily what's best for you. But while we cannot tell you what is or what is not in your best interest, for sure, it's usually, if it's inflammatory arthritis, not an advantage plan. That's all.
Thank you. Does somebody want to touch on like the difference between an HMO and PPO? And then for some of us, we have HSAs. And explain a little bit about that.
The only thing I want to say about an HSA is if you are on a commercial plan, it's not in your best interest to disclose that if you have copay assistance because there's a legal issue there. If you have an HSA and you have copay assistance and copay assistant pays it and then you submit to your HSA, that's double dipping. So a lot of companies have something in place that says legally we can't help you if you have an HSA. If you're not planning on double dipping and you don't disclose that completely, you can probably still get assistance in most cases.
Well, what makes it even more complicated is that that legal threshold or that legal limit only goes to the deductible because the HSAs typically are tied to high deductible health plans. And that deductible maximum is different than the annual out-of-pocket maximum. So it's really important if you are in a high deductible health plan and an HSA to know what that number is. It changes every year, because that is where you really face potential legal liability if you're underneath that deductible. Once you reach that, then it doesn't matter as much. But through that deductible, it does matter.
Thank you, Anna. So another question, how do pre-existing conditions impact your care plan when selecting a new insurance? Alicia, do you want to start?
This isn't something I think I can help with, because when you're trying to select an insurance and you're going through insurance brokers, like, I have opinions, but I'm not the one who's helping you sign up for your plan and what you need. You know what I mean?
Yeah.
I'll jump in for the Medicare folks. When you're choosing between the Medicare options of very high level, you're either on original Medicare, Part A, Part B, red, white, and blue card, or you join a Medicare Advantage plan. These Medicare plans will not medically underwrite. You know, if you're eligible for Medicare, if you're 65 and older, any age and disabled, typically for 2 years. If you have permanent kidney failure, you get Medicare. So you have to determine which option. If you choose a Medicare Advantage plan, which we'll probably keep getting into, those are typically managed care options. You mentioned the HMO. HMO is a health maintenance organization. You have to use their network or they don't pay. PPO, preferred provider organization. They prefer you use their providers. If you do, your costs are typically lower copays. If you go out of network, you have coverage, but it's a higher copay. These are examples in the Medicare world of Advantage plans. As long as you live within the county that the plan is sold, you have Medicare A and Part B, you could be 110 years old, diabetic, arthritis, HIV, 5 types of cancer. They have to take you. And that too can be one of the draws. So those are our 2 Medicare options. You're either original Medicare or you're in the Advantage plan. If you're in original Medicare, which does not have a network of doctors and hospitals, there are a lot of out-of-pocket costs. So individuals are typically shopping for a secondary insurance, which is often a Medicare supplement policy. Supplement policies can medically underwrite. If you're not in your first 6-month open enrollment or a very unique special circumstance, they'll ask you health questions and they may or may not sell. So I feel like we're throwing a lot of information out in a little bit of time. So I don't want anybody who's on the call to panic or taking ridiculous notes. We're all here as a resource after this phone call. And certainly during this Medicare open enrollment up until December 7th, you know, we'll help walk you through these steps. But in the Medicare world, the pre-existing conditions typically only apply to those supplemental or private insurance policies that pay after original Medicare.
Thank you,
There's
Chris.
my.
We're getting a lot of information here, for sure. So finally, to cap off this section of our discussion, we have one user submit this question. What's the number one thing you want in a policy plan if you've been diagnosed with arthritis?
So I'm going to say to that, it is so individual. You got to decide what is important to you. Whether that you can afford a lot more out of pocket to keep your doctors, or if money is extremely tight and you're willing to change doctors. There's no one set, this fits every person. So you need to decide what is the most important thing for me when I'm looking for a plan. And then I have the top 5 things usually when I list them. We're like, oh, but figure out what that number 1 is for you. You love your doctors, great. You better find a plan that keeps your doctors in network. If you have a little bit more disposable income, maybe the co-pays are higher because you chose that in-network doctor. But you need to decide what that number 1 reason is, because it's very individual. Maybe you have your arthritis hasn't advanced that far and you're on some meloxicam or methotrexate, so your costs are relatively low. So you get to choose.
It's individual is what I'm hearing, Heidi.
Yes, it is.
All right. So let's change gears now. For some young adults on this call, they may be managing their healthcare on their own for the first time. This includes turning 26, moving off your parents' or guardian's plan, or starting their first full-time job, which offers employer-based insurance. First question we're going to tackle is, what are some tips you would give to these JA families and young adults for choosing the right coverage plan? Heidi, I'm going to bounce it right at you.
So I've had 4 children who are eligible for either they've aged out or withdrew their jobs. I'm going to say one thing, just because your child starts a job, might be starting their career, take a look at their insurance plan. I know in our case, our insurance was far better what we were receiving than what my child was going to get. So he's going to stay on that plan until he's 26 and has to be kicked off. Have a game plan in place before they turn 26. You need to be looking when they're 25, what their health insurance should look like. Whether if you need to go to a state exchange or the national exchange, or they're going to receive benefits through their employer, you need to know what's out there, and you need to sit your child down because it's a lot. It is a lot, and there's a whole lot new. I mean, I can't imagine being 21, having a chronic illness, and then trying to figure out what plan's going to fit me. And oh wait, now I got to figure out how I'm going to pay for it, for that plan, and how am I going to pay for the out of pockets with that plan. So there needs to be a lot of conversation going on. And there, you know, the Arthritis Foundation, their phone number can help. There's a lot of organizations out there that can help you, walk you through the process.
Great, thank you, Heidi. All right, we're going to continue diving into Medicare now, because it really is a tricky subject. Many people qualify when they're 65 or younger if they qualify for disability. So Christina, we'll defer most of the following questions to you, but as always, you know, we welcome feedback from our panel for these questions as well. So first question, when selecting a Medicare plan, what's the best plan for someone with arthritis?
I have to go back what Heidi shared. It's completely individualized. I mean, my job would be so easy if there was one plan. I could say, here, this is it for everybody. But you have to make an individualized decision. There's a lot of individuals that are on Medicare under the age of 65. They are typically on original Medicare. At this point in time, there are no secondary or Medicare supplement insurance policies sold in the state of Ohio for someone on Medicare and under the age of 65. So if they stay on original Medicare, they are liable for all those out-of-pocket costs that original Medicare doesn't cover. And probably the most common is you go to a doctor's office visit, Medicare pays 80% of allowed amount. You'd have 20% out of pocket for every visit. So if that's something they want to consider, I would also say you have to screen yourself for various Medicaid assistance. Medicaid is the assistance by the state for those with limited income, limited resources. And it's like a ladder. Those with the least amount of money get the most assistance. They'll have full Medicaid. But there are other programs out there. We often get phone calls from folks saying, I don't qualify for Medicaid. I have too much. There's other programs. They're called Medicare savings programs. And even though your income's a little bit higher, your resources are higher, you may qualify for assistance paying those out-of-pocket costs against Medicare. So when in doubt, fill it out. Let's check and see if you qualify. Then there's Medicare Part D, as in the drug coverage. It's almost the third card in your wallet. So that's a whole nother set. And I think, Anna, you covered it very well. The costs involved in that, you need to know if there's an additional premium, a drug deductible, the copays, and what level of copay you pay. So there's no one easy decision. A lot of the time, individuals, if they are under 65 and they don't qualify for Medicaid, they may have to look at Medicare Advantage plans as the only affordable option. And at that point, we're going to revert back to a lot of topics you heard. Are your doctors on the form or in the network? first and foremost. Someone mentioned calling the billing office, and I probably chuckled. The billing offices are often very blunt and willing to share information about which plans they are in network and which ones they plan to stay in network for. So I think both options can work very well for individuals as long as you proactively know the coverage. You know, you're not going to be blindsided by a high out-of-pocket expense. The other thing, I think we've shared a lot of scary things, but for those that are on Medicare, there are a lot of safety nets. You can appeal any decision. There are steps that we can take to turn around denials. Worst case scenario, you can contact us at the SHIP. If the appeals didn't work, we can file a complaint directly through Medicare system. So the plan, Medicare, and the SHIP, us, have eyes on this complaint to try and move it forward. And we're typically successful with that. So there's a lot to consider, probably a lot more than what we can get on this call this evening. So again, I just want to reiterate, our services are available to you all year when you have questions that arise.
So Chris, the next question we have is, if someone isn't yet retired, are there any benefits to switching over to Medicare, or is it better to stay on their employer plan?
We get that question a lot. We focus the spring on welcome to Medicare. And more often, folks are saying, well, you know, I'm still working. I have no intention of retiring. So that's wonderful. If you are working when you become eligible for Medicare and your current employer is providing you with healthcare coverage, you can delay taking that Part B, as in boy. Part B is the portion of Medicare that carries a high monthly premium. It's $170.10 this year. It's actually going down. There's some good news. First time in my history I can share, the Part B premium is going down a little over $5. Was it $64.80? I'll have to double check the exact figure, but that's still a hefty monthly amount. So if you can keep your group coverage, that's wonderful. If you're over 65 and that group has more than 20, your employer plan is going to be primary. If you're under 65 and eligible for Medicare and your employer plan has more than 100, your employer plan is going to be primary. So generally speaking, it would be best to stay on the employer plan. The same holds true if it's a spouse. You know, maybe I never worked a day in my life, but I'm covered under my spouse's health insurance. If I become eligible for Medicare and I have current group coverage from my spouse, I also can delay that Medicare Part B. Then when that current worker decides I'm done, I'm going to retire, I'm out of here, I would have a special enrollment, 8 months, to pick up Medicare Part B without any penalties and without delay.
Great. And the next question is, what is the best plan to cover the costs of infusion and biologic drugs?
Medicare, so the buzzwords of Medicare, medically necessary. So injection, biologics, these are medically necessary services. So I think a question came up about injectables. Under Medicare, and it's rare we get to say Part B as in boy covers any medication, but if it's an injectable medication, it is covered under Medicare Part B. So you're typically going to have to get that in a doctor's office, outpatient setting. Medicare Part D is going to cover really any other prescription medication that's available at the pharmacy window. And I know that's a generality. There's always little nuances that we have to check into. But even those advantage plans, which I know we really caution you, especially with the marketing that's going on right now, but at bare minimum, the advantage plans have to cover what original Medicare would pay for. So it comes down to the cost. And, you know, if there's a set copay for like a specialist of $10, $15, great, we know that. But if you're going in for an infusion under Part B and you have a 20% coinsurance, maybe that's not the right plan. So again, we're circling back to kind of the same topics. Know all these out-of-pocket costs, all these potential out-of-pocket costs before you enroll in the plan. And I think it was Heidi had a great suggestion of having your last year statements, because insurance is a what if. You know, if somebody comes to us with a crystal ball and tells us exactly how many hospital admittances they'll have, how many doctor visits, how many infusions, we could probably calculate the cost to the penny. We don't have that. But your past years of health are a very good indicator of what the year ahead has in store.
We have patients who have Medicare Advantage plans, not very many. It's usually like a state retiree plan. They were police officers or teachers or whatever, and their Medicare Advantage will cover the cost of their infusion, not past the 20% coinsurance that you're used to seeing with the Medicare Advantage plan. That's not typical. And most of our patients with Medicare Advantage plans that are on biologics, they come back from the pharmacy or whoever like caught them and they signed up for that Medicare Advantage plan, and they're surprised to find out that they can no longer afford their biologic medication. In most cases, what I've seen once you're of retirement age is having a traditional Medicare plan and then also having a secondary to help them. There are, like I just said, that handful of patients who are like the state retirees that do okay with a Medicare Advantage plan and have everything covered that they need to have. But I think it's hard to ask the right questions, to know what questions to ask to make sure that your biologic medication or any other reoccurring kind of testing or whatever you need is covered at an affordable rate for you. So it's possible, but it's not likely with the Medicare Advantage plan for most of my patients, is what I want to say.
Thank you.
And just on the Medicare Advantage topic, there's so many. You know, when you're in the city, we have counties that have more than 100 different Medicare Advantage options. So another thing, kind of an overall thing that was brought up on that first slide, Advantage plans are required to have a maximum out of pocket. And we often tell folks that's your worst case scenario. So if you have these higher copays, you know, I likely wouldn't be looking for the Advantage plan with the $10,000, $12,000 out of pocket max. I'd probably try and look for one that's maybe a $3,200, $3,600 out of pocket max, which are the lower end. But you know, 100 options out there, it's a lot to go through. So I guess I keep reiterating, you're not alone in trying to figure out these costs. There's a lot of objective and unbiased help out there.
Thank you. All right, we're going to switch gears. And so life change, you know, life happens. We have family changes, people move to new states or lose their job, and that can dramatically impact insurance coverage levels and needs. So our first question deals with navigating gaps in coverage. For many people on the call, taking medication is crucial to managing their arthritis and preventing flares. For someone who's newly unemployed or doesn't have insurance, what advice would you give so that they can continue their treatment and avoid flaring?
There are a lot of programs out there, especially for some of the newer options out there. And by newer, I mean like 5, 6 years old. They have what they call bridge programs. So if you lose employment or insurance or other items, they have this gap treatment where they will just from the manufacturer send you what it is that you need that you would usually get from your specialty pharmacy. And if you're enrolled in it, especially before you lose treatment, or if you know enough to ask for it and call their helpline, you may find that if you're unemployed or your spouse is unemployed or these other options, you might still be able to have your medicine shipped to you for X amount of time, whether it's 6 months, a year, whatever.
Great, thank you. So let's go to, anybody want to add anything to that question, or we'll move on? Okay, we're going to move on. So what should you do if you become unemployed and lose health coverage?
So if you're unemployed and lose health coverage, you need to look into a few things. You might qualify for COBRA so that you can still stay on your employer's insurance plan, which would be the exact same insurance. Can be quite expensive. But also in my state, we have a state insurance, not federal. And if you lose your job, that's a life event. So you can go through the state exchange and get health insurance that way. And because you're unemployed, it probably will be a lot cheaper than COBRA. The other thing that I recommend to people, my rheumatologist office, if they find out somebody's like lost their insurance or whatever, they do a reasonable, like, okay, we're only going to charge you $40 to come in to see us versus the $200 or $300 that insurance is worth. So always talk to your doctor's office, and they also might be able to get your medicine through the pharmaceutical rep and give you a few months to tide you over until you find another job or you get put on Medicare or Medicaid, whatever the circumstances are. There are lots of programs out there to help, but it's going to be your job to be doing your due diligence to figure it out and calling and meeting with the correct amount of right people. So, and I know
Other than those bridge programs, a lot of times we have samples available to us. So even if you're usually an infusion patient, depending on the comfort level of your physician, say you're on Symphony Aria, and you can't get your infusion on time or you don't have the insurance to cover it, we might have Symphony as a sample that's an injectable. Now, if your physician is comfortable with it, we may be able to sample you until you're able to get your infusion again. If you're on an infusion, it's usually for a specific reason, like it's weight-based or disease activity and all this other stuff, but something is better than nothing. So it doesn't hurt to ask or look into it. It doesn't hurt to say, like, is there something else we can do until I have coverage again, or until I have coverage that I can afford to support, especially if you're on like a Medicare plan where you are not allowed copay assistance legally, that kind of stuff.
Thank you. So what if you're switching insurance plans?
So if you're switching insurance plans, there are a number of things to look at. All of what we've talked about before, if you know what your new health plan is going to be, definitely look at the formulary coverage requirements, cost sharing requirements, provider networks, all those things. But in addition to that, I would also really make sure you know what the transition fill requirements are. Most health plans and exchange plans, have some requirements in place too, some protections such that if you are on a particular drug and it's vital for you to stay on that drug in order to remain stable, and perhaps the health plan that you're going to doesn't prefer that on their formulary, that there is a policy in place. Usually the transition timeframe is about 60 days so that you can work through the appeals process. If it's a step therapy requirement, whatever it is, some sort of physician override, that there's time to work through that process before you would essentially not have cost sharing protections to access your drug. So I would look for that. Sometimes those kinds of things can be difficult to find in plan material. So again, I would just be really comfortable getting on the phone and having a conversation with someone from the new health plan to ask, what their transition protocols are.
Great. Thank you, Anna. We also had a question from somebody that said, I'm getting off insurance and won't have access to Medicare anymore. What should I do? And I can jump in on that one. I would suggest that you explore the Ticket to Work program. That's a benefit that's available to people who are on SSDI, and it bridges you into working so that, and I actually used that when I came back to work, and it gave me that safety net and the confidence that, God forbid, if I flared and wasn't going to be able to work full time again, that I could quickly go back onto Medicare if that were the case, and I've got expedited return. So that's something that you can explore through the Ticket to Work program. So we're going to move on to our next section, and the next topic is something that's on everybody's mind: treatment and medication affordabilities. Doctor's appointments, medications, surgery, and complementary therapies to manage arthritis can all add up. To start with, we'll tackle a question that came up a lot in our registration, which is, how can someone maximize their coverage of costly medications? One person wrote in, I require a high-tier medication, I'm on copay assistance, but it still isn't enough, and I'm struggling to afford my medication. What else can I do? Alicia, let's start with you.
I think that copay assistance may not be enough, but especially if you're on like a monthly instead of, I know some of them are every other month or every 6 months, and that makes it a little bit tougher. But if you can figure out how to time anything you have copay assistance available to be earlier in the year versus all your other testing and appointments, that will start to eat up your deductible. And if you eat up your deductible, you're just in co-insurance. And if you can eat that up, you're just into a copay territory, and you want to get to your maximum out of pocket. And it's super tough. But if you do plan ahead and you have the benefit to be able to kind of plan out where you can have those appointments, and then if they bill it first, even if you see somebody else first, whoever bills first and whatever gets the insurance first is what's going to get precedence. And if you know what your maximum out of pocket is, and you know what your drug cost is about to be, which you can call your insurance, you can figure that out. I know it's extra work, but if you have other stuff pending, try to figure that out and see what's worth it. And if you can wait for other things until after you have 1-2 treatments, you may find that your out of pocket is mostly eaten up. And if you have a copay accumulator plan, most insurance companies, if it's a pharmacy benefit, have a workaround. So try to figure out how to find the right person at that manufacturer that can help you get that workaround, because they'll give you money right into your bank account instead of giving you a card and then they don't even know. And you can make it a little bit further and spend a little bit less and take care of yourself and your family a little bit more, you know?
Thank you. So our next question, similarly, this person wrote in, my insurance continues to make adjustments that increase my out-of-pocket each year. My copays no longer count towards my deductible or out-of-pocket maximum. What should I do? Heidi, I'm going to pitch that one to you.
Don't you love it how insurance companies do that to you? So what I look at, what Alicia was just saying, your copay, well, I can speak English right now. The copayment assistance really plays in, like in our family, we don't do any extras in January. So no MRIs, no CT scans, no blood work. If we have to go to the room, we try to plan it just where we're getting our infusions, because that will eat up all of the cost in my family. And so that we can go through the rest of the year, we do have to pay for copays out of pocket. But I don't have the 10% that's owed on top of everything else once that deductible is met. And it's tough. I also plan our appointments. Sometimes you can get away, like my doctor's like, oh, you need to come in every 2 months. And I'm like, every 2 months, or can we go 3 months? Yeah, 3 months, definitely you can go 3 months. I just said 2 because that's the standard. So push back a little bit. I would never tell anybody to skip their medical care, but sometimes people just on their end, it's like, oh, 2 sounds good. So push back on your doctors a little bit about when they're scheduling the appointments and what you need to go in to be seen for. You know, do you need to run to the doctor for everything? Sometimes you do, sometimes you don't, but keep all of that in mind, because those costs really eat up into your budget. So, but if you're receiving the copay assistance, use that to your maximum, to your benefit.
I agree with all that. I think being your self-advocacy is really important here. Have the conversation with your doctor too. Your doctor may not have time or may not think about bringing up issues of cost to you in the exam room. I think it's something worth proactively bringing up if it is a demonstrable problem. Also, your employer, if you are getting your insurance through your employer, you know, there's usually a pretty big disconnect between, you know, that your employer is using typically a benefit consultant to help them make decisions about what coverage they're going to offer their employees. How that coverage is actually impacting their employees is where there's often a disconnect. And I think people are often afraid to bring up questions or push back around challenges with coverage to their employers. But I think it's really important to have honest conversations with your employer about whether the healthcare that they're offering you is really serving you. If you're on Medicare, it gets really tricky with copay assistance because it's illegal to use copay assistance in Medicare. A lot of people don't know that. And when you're transitioning from private insurance, where perhaps you're used to using copay assistance for your medications, and then all of a sudden you're on Medicare and you're told that you cannot use that copay assistance anymore, now you're on the hook for whatever those cost sharing obligations are. Something I would flag that won't be unfortunately available until 2025, but is still vitally important, is if you have a Part D, that's a prescription drug benefit. So if you're on traditional Medicare and you have a self-administered drug, it's probably a Part D, you have a Part D plan. The Inflation Reduction Act that was just passed over the summer includes a cap, a $2,000 cap for your out-of-pocket expenses in Part D. And one of the really interesting things about this is it also includes what we've been calling a smoothing mechanism, so that you don't have to pay that $2,000 up front. It allows you to spread it out over the entire plan year, which I think adds up to about $167 a month. So that's going to be a game changer for a lot of people on high cost drugs in Medicare Part D. Doesn't go into effect until 2025, but something really, really to be aware of.
And I just want to add one thing to this conversation. I know for me in the beginning of our journey, I was really embarrassed to talk to people about, I can't afford the drugs you're prescribing, or telling, I was embarrassed to tell them, I can't afford this. Don't be embarrassed. If your doctor doesn't know, how are they going to be able to help you? They know we're not multimillionaires coming into this. So keep the conversation up with your pharmacist also. That was a huge struggle for me to go, oh, I don't know how we're going to afford this. I didn't want people to know that we were struggling. So.
Also, when it comes to employers, and if you have an employer plan, a lot of times they don't know what they're signing up for. I had somebody try to sign us up for a plan, and when they told us the insurance company may give us back a few $1,000s if we didn't meet something, I had questions. I'm like, but why? I've never heard about an insurance company trying to give me money back, right? And it all came down to, at the end of the day, biologics wouldn't be covered, durable medical equipment, and a bunch of other stuff wouldn't be covered. And when I told them, I said, our patients, if they had this kind of a plan, they wouldn't have access to care. And his response is, you have to do what's best for you and your employees. My employees are not chronically ill. They don't have but we understand what it's like for our patients to not have access to care. It's just everybody doesn't understand. But I've had patients who don't have access to care. And when they push back with their HR department and have that kind of assistance, they can either get an exception for coverage. And it may not be, the easiest route. It might not be like buy and bill. They might need specialty pharmacy. Things might get delayed because of like kinks in the works, or they may have to try some other stuff. But sometimes if it's an employer plan, don't go through your insurance company, go through your HR department and they can help you. But on the other end, even if you're going through your insurance company, don't just call customer service and ask for help. Don't just ask your doctor's office for help or whoever. Ask them for a patient advocate. And we've started doing it, and it feels sneaky, but it's not. We ask our patients, get a patient advocate from your insurance company. Don't let them know we're on the phone. Keep us on mute, but we're on three-way. And when they get on the phone, they're like, oh yeah, we'll get oh wait, by the way, my doctor's office is on the phone and we can help you navigate this prior authorization issue. We can get things expedited. Let us tell you how this can be better, because even with peer-to-peers and all this other stuff with appeals and whatever, they don't understand fully, and they have certain prerogatives to not approve expensive treatments. And obviously, our patients need expensive treatments. That's all that's left when they're at this point. But if you have the right person on the phone, not from customer service, not from appeals, not from, prior authorizations, it's a patient advocate, they can sometimes push you through. Also know your state laws and know what your insurance commissioner can do to help you if you know what those state laws are. And you can get really far a lot faster than a lot of people, but sometimes people just give up and stop trying. But sometimes there are still options available.
And I would just add for the Medicare folks, we talked about Medicaid and the levels of assistance. Even for those who have too much to qualify for those Medicaid assistance, Medicare does have what's simply called extra help. And it's Medicare helping to pay for prescription drugs. So it can eliminate a lot of out-of-pocket costs. And I know in this conversation, even with that assistance, sometimes the drug costs can be too high. So reach out, I think, is the end of the day. Reach out, whether it's your employer plan. You can reach out to us at the SHIP. Alicia, you mentioned the insurance commissioner. Our program physically sits at the State Department of Insurance. And, you know, if you're Medicare, call me, but we help with others. So if you're on other types of health insurance and you're having an issue, there's an online complaint form if you don't want to talk to us, but there's also another toll-free number with individuals in Columbus, Ohio, who will help walk you through and make sure that everything your insurance company is doing is on the up and up, or they'll make them, you know, revert and pay.
Even if our insurance commissioner isn't able to help us, say it's like a Medicare issue or it's like an ERISA plan or something, they, in my state, my current commissioner will say, hey, I'm so sorry, I can't help you, but this is the next step. Here's the information. This is where you give it to. But also, even if you don't qualify for assistance through other options, sometimes if you talk to the right person in your office or at your insurance company, they can tell you what step you can take to get more help. It doesn't hurt to ask.
And in the most egregious of cases, we'll never hesitate to tell someone, you know, let your congressman know, you know, take it to the next level, but, you know, don't go unheard.
All right, our next question. So what should you do if your prescribed treatment is not on their formulary or not covered by insurance?
Sometimes.
I'll go quickly for the Medicare. We can ask for exceptions. Medicare Part D plans, whether it's Part D or it's part of the Advantage plan, have to cover medications in all classifications. So ideally, we'll look to see if the one in the class or on the formulary will work. If not, we will ask for an exception. And certainly, going back to the individual state, if there's a possibility we can switch plans mid-year to get a covered medication, we can also do that.
I feel like there's a rule too, I can't promise, but with Medicare plans, if they can't continue to cover it, say it's like on Part D instead of Part B, you have like a time frame before you have to switch over. But I think
it's 60 days. And yet in the past, and again, each year, it used to be if you were prescribed the medication and you had it filled one time, they'd push the plan to make them pay for the full year. And same thing with the exception. If you get the exception, it is good for 1 calendar year. We might have to ask again.
I think if you know you need a change, or there may be a need for a change, say you're on Enbrel because it's only Part D or it's only prescription, and you know that you're about to become Medicare and there isn't like something to carry over, make the appointment before your insurance changes. You may have those 60 days, you may have that year, but you may not. And if you don't, it's better to have a plan. And it may be in office and it might not be convenient if you're used to giving yourself injections, but some of these are every 8 weeks or every 6 months, and you don't have to be in the office all the time, but it's better to talk to your doctor about it before your insurance changes, so you have a plan. Because if you're trying to get in after your insurance changes, and most people that's going to be in January, which is when everybody is changing, so you want to make sure that you have a plan to go forward before everybody needs a change.
And I was also going to say, if you have private insurance or an employee-based insurance, we utilizes our insurance nurse that is assigned to our family. And she has 3 times now advocated to get medicine for my children that wasn't on the formulary, that insurance had denied. And once she heard what the reason was and why, she was our advocate, and we got the medicine the next day. So don't think everybody in your insurance companies against you. And I've asked like customer service that's helping me out. I'm like, okay, what am I supposed to do? What's my next step? And people have hearts. They will tell you 90% of the time. Just remember, no doesn't mean no. You just haven't found the right answer yet. So keep pushing at it. And I know it's really hard having a chronic disease, and then you have to spend all this time fighting with the insurance companies and, sometimes even fighting to get your doctor's appointment. But keep at it. Eventually you will get it.
So
I
next,
just encourage folks. Oh,
sorry,
sorry.
Chris.
I just encourage folks, we've been in a public health emergency now for several years. And at one point it will come to an end. Public health emergency status is currently in place until January 11th of next year. When that ends, state Medicaid offices will be able to drop those who would not have otherwise been eligible for Medicaid programs. So it is possible, if we see that health emergency end, individuals who are on, say, Medicaid expansion and now are eligible for Medicare may not have Medicaid moving forward. And these are individuals that may not have taken the time to sign up for Medicare when they turned 65 because they were on that expanded program. So I think we're going back to being proactive. You have your coverage, please, keep an eye on things that are happening. And if you can fill a 90-day prescription before losing that type of healthcare coverage, that gives you a safety net of time to figure things out. So I'm not trying to be the voice of gloom and doom, but there are big changes going to happen when that public health emergency ends, and use these resources as needed and all these helpful tips.
Thank you, Chris. So how can I appeal to my insurance company to pay for other therapies like physical therapy and acupuncture? Are there ways to make them more affordable? Anna, do you want to start?
Yeah, there's a lot of variability on what health plans will cover when it comes to things like physical therapy, acupuncture, chiropractor services. Some plans have caps on how many visits or how many of those services you can receive. There's a lot of variability. I think this is where if you do have a flexible spending account, or even if you do have an HSA, those are dollars you can use for services like that. Most services like that are IRS eligible. Appealing sometimes can work for things like that, but sometimes it won't. I think it really depends on your health plan and what their coverage terms are. I think, thinking about the long term, if you know that you're going to have a particular health plan for a while, or you're going to be with you're with an employer and that's where you get your health care, that's where you would again go back to the HR department and have that conversation about what your needs are, so that when they're having a conversation with the health broker for the next year, they can put that, at the top and make it a priority to think about services like that.
Fantastic. Heidi, I'm going to throw another question at you. Over the years of managing you and your family's care, you've learned a lot of tips and tricks to managing care a little bit easier, like talking to your provider's office, learning diagnostic codes, and more. Can you share a couple of your top tricks for patients?
You know what? This is the one that I tell people all the time that should be common sense. Be nice. Be nice, be respectful. That's my top. When you're nice to people, they will go out of their way to help you. And don't be embarrassed. Tell them, I can't afford this, but also don't be screaming and calling them names. Being nice gets you so far and has gotten us a lot of things covered that we were told, nope, you can't have coverage on that, because I was nice to them. Also, you got to learn how to play the game, like how to maximize all those dollars. It sounds overwhelming, but once you learn, know how the copay assist programs work. And the other big thing is if something's going on in your state, like your state's not covering chiropractor or acupuncture or naturopath, then push hard on your state elected people. We have a law in Washington that's covered. It's because we went after and said, this all should be covered in our medical I didn't go into advocacy going, oh, I'm a lobbyist. I needed to make change so my kids could have a better future and have their medicine covered for them and their care covered for them. And it happens to be that I got to go and change law, then that's what I got to do. So, but yeah, my talk, be nice.
Thank you, Heidi. How can you maximize your coverage for doctor's appointments and lab testing? Alicia, you want to take a swing at it?
I think that the best thing you can do is be aware of what your coverage is. Is it a deductible? Is it this? Is it that? And if you need lab testing, but it's an out-of-pocket thing that you're working on, and you can potentially get it covered by getting a prescription filled, your doctor will probably not notice, but be okay, even if they do notice, if you're 3 weeks late on your testing for your lab because you were waiting to fill a prescription for a 3-month stint, that kind of thing. And you can talk to them about how necessary is it for me to get my EKG right now? Can I wait a month? Can I wait 3 months? Do I need it now? Or are we curious, or is it necessary? And it doesn't hurt to have those conversations. And just like Heidi was saying, there is no reason to be embarrassed if you have coverage issues or if you're not sure you can afford things. Most of us cannot. We've seen how much healthcare has changed. We've seen how much our out-of-pockets have come up, how much we're paying for our premiums and all this other stuff. It's not news to anybody, and it's not embarrassing. We can talk about it. How necessary is it that it happens now before, especially if you have access to like a copay assistance program, before I meet my out-of-pocket, and can I do this later? And I've had my own physicians say, you know, it's okay. You don't have to come back in 2 months. You can go back in 3 months, but they're used to that 2 month or that 3 month where they're on that roll. It doesn't hurt to talk about it.
Open communication.
Yes.
So important. All right. We also received several questions about biosimilars, which are equally effective biologic drugs that will be expanding in the market in 2023. We will have a separate webinar about that topic on November 9th at 6 p.m. Eastern. So please register for that at arthritis.org/webinars. All right. So we'll take some time to answer questions, but keep in mind we've received several before and during this event. We'll try to get through as many as possible, but as a reminder, any questions that we don't get to, we strongly encourage you to refer to our helpline at arthritis.org/helpline. So I have 2 questions for you. I went from Medicare to AARP Medicare Advantage. Why can't I return to Medicare?
You can. So we're in Medicare open enrollment, October 15th to December 7th. This is your time to choose. Do you want to be in that Advantage plan or back in original Medicare? So going from, let's see, you're in the Advantage plan, moving back to original Medicare, the easiest thing to do would be to pick your Part D prescription drug plan. If you're going back to original Medicare, you will need that prescription drug coverage. Enrolling in the standalone Part D plan will automatically disenroll you from the Medicare Advantage plan. The second component to that choice is shopping for secondary insurance. You know, you'd want to first see, do you have access to group health coverage? Likely not, or you probably wouldn't have gone to the Advantage plan. Do you qualify for Medicaid to act as your secondary coverage? If not, then are you shopping for that Medicare supplemental insurance policy, which could potentially include medical underwriting for any pre-existing conditions? So you can go back to original Medicare every year during open enrollment, but that decision must be made by December 7th. You try and enroll on December 8th, it's too late.
Okay, Chris, I've got another question that's going to be right up your alley. Don't we pay a penalty if we do not sign up for Part B when first eligible? How much is that penalty for each year we wait to get Part B?
Yes. So Medicare Part B as in boy has a penalty. If you do not take Medicare when you're first eligible, let's say you're turning 65. I'm healthy. I don't want to pay $160 some a month. Forget that. And then 5 years goes by. And now I've got some doctor appointments and I think maybe I should get that medical coverage. Well, I can sign up every year during a general enrollment period, which is January, February, and March. In the past, you had to wait till July to get coverage, but the Inflation Reduction Act, or different act, is going to change that. You'll get coverage the first day of the next month. But there is a 10% penalty for each year, 12-month period that you delayed. So I said 5 years. Let's assume it was a full 5 years. That's 50%. So 160, I'm not good at math on the fly, but that's over $80 a month tacked on to your Part B premium. So we want to avoid the Part B penalty. The one and only exception to that penalty that we talked about earlier are individuals who are working past the age of 65 and covered by their group health insurance, or their spouse is still working and covered by group health insurance. That is the only exception to that penalty. So those folks, again, would have a special election period, 8 months to pick up Part B, no penalty, no wait. And if they question it, I highly encourage folks to give us a call Social Security or 1-800-Medicare.
Thank you. And our next question is, I'll be applying to graduate school soon, but some don't offer insurance. Should I just not apply to schools that don't have insurance?
Oh, no. Apply to the school that you want to go to. There's the federal exchange and the state exchange, and you can buy your insurance through them. And depending on, I imagine, graduate student, you're not going to have a lot of money. So a lot of them are based on income. So your premiums will be really low, even could be zero. So check out the state, depending on what state you live in, whether you have a state exchange or going through the federal government. So.
Yep.
I'd add too, a lot of grad students can't work. The school schedule is too hard. They often qualify for Medicaid in their state.
And
If you go to healthcare.gov, it'll tell you, you can find out whether the state that you live in or are going to graduate school in has a state-based exchange or a federal exchange. And you can also look up all of the information about what that covers, what those costs might be, whether you're eligible for subsidy. All of those kinds of things are publicly available, which is really wonderful. And you can look at plan information. That's all publicly available to you on the exchange plans. So it's really helpful. The premiums can be high. It can be out of reach, but to what Heidi was saying, if you're going to graduate school and you're not making money because you're not employed, then you are likely going to be eligible for subsidies, and that can make a huge difference. So definitely look into that. It's a really important safety net.
Great. Our next question. Some people on the call may be caregivers of children with arthritis. What advice would you give about selecting the right care plan if you're a parent or guardian to ensure your child gets the best care possible?
Again, we go back to that individual. You got to figure out what's more important for your family. But the other thing that, since we're dealing with children, a lot of children's hospitals have financial aid. It's not there for low income people, because low income people generally qualify for Medicaid. It's for the middle class. So you check into if your child is going to the rheumatologist at a children's hospital or associated with one, check out your children's hospital financial program. I know mine here in Seattle has a very generous program that's meant for middle class people. So we don't have a copay when we go to the hospital to see those assistants. They take whatever my insurance pays.
Thank you, Heidi. All right. Well, a big thank you to our incredible panel for lending their time and expertise this evening. I think I can speak on behalf of our audience that we've all learned something valuable to better our care this evening. Before we sign off for the night, just a reminder that we have several resources and events coming up to help you manage your arthritis. The Arthritis Foundation's RX for Access Toolkit has abundant resources to help answer your lingering questions about insurance and help you craft the right plan for you. Visit arthritis.org/RX for access to get started. Remember, the Arthritis Foundation's trained staff can help you navigate arthritis challenges, from treatment questions to insurance and healthcare access questions and more. Visit arthritis.org/healthcare to learn more. And webinars. As I mentioned, we've got our biosimilars webinar coming up. What should you know? November 9th. Coming soon, many patients for brand name reference biologics will expire. Expanding access to biosimilars. Learn what this means for you and how this how this inflammatory arthritis drug can fit into your care plan. You can learn more about this webinar and register at arthritis.org/webinars. We have a podcast, so visit arthritis.org/podcasts and listen to a library of educational topics to help you manage your disease. As a reminder, taking just 10 minutes to fill out the insights assessment can help develop programs that speak to what's important to you. Visit arthritis.org/insights to take the assessment. Lastly, please note that in a few days, you will receive a survey asking you about your experience. Please take the time to fill out this survey completely and honestly so that the foundation can best serve you in the future. Thank you so much for joining us tonight. Take care, and we'll see you soon.